Good afternoon, everyone, and welcome to Grand Rounds. Today, it's our great pleasure to have Dr. Bernie Bissett presenting on treatment of dyspnea from ICU to COVID recovery. So Associate Professor Bissett is a physiotherapist with more than 20 years experience in treating patients in the ICU and the acute care setting. She's worked in London, Sydney and Canberra over her career, and we're lucky to have a homegrown researcher presenting for us today. Her PhD focused on training of inspiratory muscles to enhance recovery in patients who are ventilator dependent in the ICU. So thank you, Bernie.
Thanks, Nicole. Thank you very much for the opportunity to present. I love coming back to Canberra Hospital. I still think of myself as a clinician, even though I've defected to academia a little bit, but my heart, I think, will always be here in the hospital. So thank you for the invitation. So today I just have a couple of things to say before we get going. First of all, I have no conflicts of interest to declare. I will be mentioning potentially specific products on my way through just because it's what's available in Australia, and I'm just keeping it real, but I get zero kickbacks from anybody. And you will see some patient images in this presentation. They've given their permission for them to be used, but please don't share them more widely. So my journey in terms of exploring this topic started way back in 2004 when I was at the time the senior ICU physio here at Canberra Hospital. And it's been quite incredible to go on the journey for the last 20 years, exploring how can we help our patients breathe better. And what I'd like to share with you this afternoon is pretty much the last 20 years of my career and what I've learned, not just in ICU patients, but it applies really broadly across lots of different patient groups. I'll be sharing with you the most current evidence that we have, including data published just last year. So thank you for joining me today. Before I keep going much further, for those who have not come across it before, what is inspiratory muscle training? Very simply, it is resisted breathing on inspiration. Just like we go to the gym and lift heavy weights to get our biceps bigger, we have discovered that we absolutely can train our patients to strengthen their breathing muscles. So primarily we're strengthening the diaphragm, but we're often strengthening in accessory muscles as well. The key evolution that's happened in the last 20 years particularly is the devices have become more sophisticated. So what's really crucial for us to train patients well is that we have a titratable resistance. It means that we can guarantee patients are working at a particular threshold or a setting, usually measured in centimetres of water. And that's really important to make sure we can increase the resistance over time. That's how we generate training effects. Up until now, the other sort of devices that physios were using were variable resistors and things, but it just depended on how fast the patient breathed in, essentially, as to what work they were doing. So this was an absolute game changer for us in terms of being able to prescribe training accurately and to get training results. So just a little bit of context before I launch into the rest of this talk. Okay, so I'd like to focus this afternoon on the importance of treating dyspnea, primarily because it overlaps so crucially with the quality of life of our patients. We have seen this as clear signals in our intensive care patients in our own research here in Canberra, and it's a clear message right across the patient spectrum. Believe it or not, in just half an hour, I'm going to try to cover what we know in ICU patients, in athletes, in patients with COPD, heart failure, Parkinson's disease, and we'll round it out with some COVID-19. So strap yourselves in. I hope this is something that is going to be relevant for everybody across almost every area of medicine. There's a lot of things I can't touch on today. Ask me questions at the end. So what have we learned about the experience of patients and dyspnea in intensive care? It's a little embarrassing that we've only started measuring such things in the last few years. But fortunately, a group in France published a study on this just last year. They looked at data from 612 patients who were invasively mechanically ventilated. And they found 34% of these patients could report dyspnea. And interestingly, the length of stay was not particularly predictive. And when they followed these patients up by day 90, they found 29% in the dyspnea group had detectable post-traumatic stress disorder, compared to only 13% in those with no dyspnea. And it does appear that that PTSD was related to the frequency of dyspneic episodes prior to extubation. So what that tells us is that our patients' experience of breathing difficulty matters, not just while they're in ICU on the ventilator, but certainly it has a lingering effect. And this resonates with some of our other studies that have followed up ICU patients, showing that some of their most traumatic memories are around their difficulty breathing. Perhaps not surprising if we think about the mechanics of what we do to people in ICU. So here's what we do know about what happens to breathing muscles in ICU patients. And this is not particularly new. This was published back in 2008. But we have a very neat study that looked at patients who were invasively ventilated between 18 to 69 hours, and they compared those to those who had controlled mechanical ventilation of just 2 to 3 hours. And this study very neatly demonstrated that there's absolutely detectable atrophy happening with both type 1 and type 2 muscle fibers in the diaphragm. And we're also seeing, obviously, proteolytic processes happening as well. And these changes are not just a widespread occurrence of their global critical illness. They are isolated to the diaphragm. So really interesting. The diaphragm takes the approach, use it or lose it, like any of our muscles. And if the machine's doing the work, our body will start dismantling it. So this is not particularly surprising to me as someone who worked as an ICU physio for many years. We saw our patients get weak and get weak quickly. But here's what else we know. In studies that have looked at measuring respiratory muscle strength, so we do that through the maximum inspiratory pressure maneuver, basically getting the patients to go against some resistance, we find that certainly the weaker the patients, the lower that MIP score, the longer the duration of weaning from the ventilator, the harder it is to set them free. Interestingly, it's also correlated with some limb weakness as well. But the kicker is, if we allow these muscles to atrophy quickly as they do, then we actually have a fair bit of work ahead of us to set our patients free from the ventilator. Our own work here in Canberra echoed this, and we actually published this several years ago before we had some of these neat studies. We found that even following ventilator weaning, many of our patients had detectable inspiratory muscle weakness, around about 40% are predicted. And other studies have shown that if their strength scores are less than about 30 centimetres of water for their MIP score, that's even associated with 1-year mortality. Again, what we're seeing in the pointy end affects what happens down the track. Just to give you a ballpark for those who are not familiar with MIP measurements, if you to measure my MIP on a good day, I'm in the 90s, maybe 100. I get my students to do it. Sometimes they get very competitive. They're up to 120 unless they're athletes. But it's very common for my ICU patients stuck on a ventilator to have a MIP score of, say, 12 or 15. That's the difference that we see. Now, with our patients, we were one of the first groups, and we published this work back in 2015, to say we actually measured the dyspnea experience of our patients back then. And about 40% of our patients who have successfully weaned from the ventilator reported an RPE score or feeling that work of breathing more than 0 at rest. And these are typically patients without any underlying lung disease. And not surprisingly, if they perceived exertion at rest, it was even worse when we tried to exercise them. So just because they're off the ventilator doesn't mean they're out of the woods in terms of their respiratory muscle strength and therefore their experience of how difficult it is to breathe. And I think we underestimate to our peril how much that can impact on their quality of life, their exercise tolerance and everything that flows from that. So my summary so far is dyspnea is reasonably common in our ICU patients and it is quite traumatic for many of them. But the good news I can bring you today is it is absolutely treatable. But before I launch into the mechanics of how that works, I would like to share with you some of the most important lessons we learned about inspiratory muscle training and how it works. And interestingly, we didn't learn that so much in the hospital as we did from the Institute of Sport. So when we started doing our research here, I had some very interesting conversations with the head coaches and the trainers that were looking after the endurance athletes. And let me tell you, the Olympians are all over this. They've been onto it for a while, and I'll show you why. Here's what we know about how training the breathing muscles can actually improve exercise performance. Come with me on this. It's been established that there's a respiratory muscle metaboreflex. Essentially what happens is that as the diaphragm fatigues and it produces metabolites, these transport around the body and they cause a vasoconstriction in the peripheral muscles, all right? So basically we're redistributing the blood flow to the fatiguing diaphragm. Your body's going to prioritize and say, we're not going to spend energy and perfusion on the legs pedaling around on the cycle. We're instead going to redistribute it to your breathing muscles. And that's been shown in multiple different kind of athletes. It's a really consistent message that we have seen. So not surprisingly, if we take the diaphragm to fatigue, we have poorer leg muscle fatigue and worse performance. But the cool thing is that if we train it, if we then make the diaphragm and the breathing muscles stronger and require less oxygen, essentially, then we see the reverse. And we see that there is then more perfusion to spend peripherally, and exercise performance improves as the perception of fatigue changes. And we have seen this across lots of different athletes, runners, cyclists, swimmers. I'm just summarizing a whole chapter of my thesis here for you in one slide. But essentially, things like a reduction in 4-mile run time, your cycle time, or even a swim time, absolutely these are detectable. Now, you might look at these measures and go, hey, Bernie, are we really going to get that excited about a 1.5% improvement? These people going for a gold medal, oh yes, they're very excited about that. And these are in ultra-trained athletes. So for our patients who are incredibly weak, we absolutely see these kind of similar kind of improvements. But some of the key lessons that we've learned from our athletes include we need to work our patients at high intensity. A little side note, if you look at some of the very early studies that have tried to apply inspiratory muscle training in different patient groups, that was so conservative. They gave them 20 or 30% of max resistance and they got nothing. So it's really important that we go high intensity, at least 50%. That's basic strength training principles, if you think about it anyway. Certainly we can see that if we do that, the athletes report reduced dyspnea at maximal exercise. If you have a look at diaphragm thickness with an ultrasound, you can see improvements 8 to 12% after just 4 weeks of training. However, we can definitely see significant improvements in strength as early as 2 weeks. Certainly in cyclists, we have seen that. So we could have a whole conversation about, is that purely muscle, is it nerve? It's probably the whole package deal. There's probably efficiency and training that all comes together. End result being that we can absolutely expect changes early. So hold on to that idea while I take us back into the ICU. So here's what we found out about inspiratory muscle training in an intensive care context. We've applied the same kind of training approach. We said, okay, let's do strength training, a minimum of 50% of their maximum. Let's do 5 sets of 6 breaths, so 30 breaths total. This training takes less than 10 minutes if you give them plenty of rests in between, but we are physically disconnecting them from the ventilator and putting them on this little resistance trainer for those 6 breaths in a row. It might sound a little crazy, and when we first started doing this, we kind of just looked at each other and said, is this crazy? I don't know, let's give it a go. And we didn't break anybody. And in fact, the reverse happened. People seemed to get better. So of course we had to measure it in a randomized trial. I'll share with that in a second. Unfortunately, this video hasn't quite downloaded, but this is a picture now of me actually doing some of this training with a patient many years ago. We obviously need to do it in patients who are awake and alert and able to understand what is happening. So one of my caveats for advocating for this training is please do not do this to unconscious patients, patients who do not understand that we're going to give them intermittent resistance where it's going to feel jolly hard to breathe. I think that amounts to torture if we think about the psychological consequences. So please make sure we're only doing it in people who can understand. So here's some results from the randomized trial that we conducted here between 2011 and 2019. My goodness, that's a long time to collect data. My PhD was actually done halfway through, but we kept going to the end so that we had a fully powered study. Feel free to read up on this, but essentially we had 33 patients doing the IMT, 37 in the control, mean age of 60, slightly more males, most common diagnosis being sepsis, multi-trauma, pneumonia, or some Guillain-Barré thrown in as well. Here's what we found. Really importantly, the group that had done inspiratory muscle training had significantly more improvement in quality of life on 2 different measures. We measured it with the EQ5D and the SF36 tools, one far more detailed than the other, obviously, but we had a clear signal for both. And this echoed our previous results of looking at what happened in patients following ventilator weaning. So we do not think this is a fluke. And the more I study this, the more I'm convinced that quality of life and dyspnea are very closely related. There's so much psychology in breathing and so much about how a patient feels about every aspect of their lives. We also found that only the IMT group had a statistically significant reduction in their dyspnea score, and importantly, the magnitude of that reduction was more than the minimal clinically important difference of 1. So that's the scale out of 10. So that's really promising that we saw that both for dyspnea at rest and dyspnea during exercise. So if you want some more non-Canberra research, feel free to have a look at this systematic review, which was published in 2018. Actually, that's a bit of a lie because we've got some data that came into this systematic review as well. But the other cool bit of information that may encourage our ICU colleagues to be using this is that we think that we can hasten ventilator weaning. And if we can make a mean difference of 3.2 days with lots of different kinds of training approaches, saving even 1 day in ICU, as we know, saves about $5,000. So in and of itself, it absolutely is warranted, I think. Okay, here's the study that I mentioned about what happens if we do this training for just 2 weeks following successful ventilator weaning, because we know that many of these patients still have residual weakness. Again, in this study that we published in Thorax back in 2016, this is entirely Canberra data, we saw significant improvements, not just in maximum inspiratory pressure in the IMT group, but also in quality of life. So that's really exciting to be able to see that consistent message coming through. So I hope I've convinced you that IMT absolutely does have a place in the modern approach to rehabilitation for our ICU patients. But let me take you on a quick whirlwind tour of some of the other conditions, and you're going to see echoes of the same themes. I won't spend quite so much time, but just to show you what we know. So a lot of our early data about inspiratory muscle training has come through the COPD population. There's a very neat study here by Rick Gosselink and his colleagues in Belgium, and they had a look at many, many different studies in this meta-analysis, and there's a very clear signal that not only does inspiratory muscle training improve strength in this group, it improves their 6-minute walk distance, it reduces their dyspnea, and it improves quality of life. I think that's pretty awesome. Of course, this is not for a second to say that pulmonary rehabilitation doesn't have a place. Of course it does. I'm a physio. I'm never going to say, don't do the whole body exercise, just do this one thing. Of course, we want whole body exercise as well. But we also know that plenty of patients with COPD can't or won't, unable for whatever reason to get to pulmonary rehab classes. Offering them some inspiratory muscle training may be a really smart move. And here's another study that I think gets less attention than it should. This is a neat study that compared inspiratory muscle training compared to sham training over a 12-month period. These patients did 15 minutes a session twice a day, just 3 days a week. Pretty manageable if you think about exercise burden for the patient. And they had significant long-term benefits. They had better exercise tolerance at 3 months. They had better quality of life at 6 and 12 months. And check this out, they had a reduced hospitalisation to do with their COPD by 30% in the IMT group. That alone should have our physiotherapists in the community excited about getting their patients onto some inspiratory muscle training. So I think there's reasonably compelling evidence in the COPD population. What about heart failure? So clearly the mechanism of dyspnea is incredibly different in heart failure. I'm not even going to try to do that justice in this presentation this afternoon, but it's very clear that even many patients with chronic heart failure also have weak inspiratory muscles, and that could be at least partially contributing to the dyspnea that they experience and their poor exercise tolerance. So clearly we're not suggesting that inspiratory muscle training is going to change the underlying pathology. However, we're going to take the edge off that element that is contributing just from disuse essentially. And so there's a nice systematic review and meta-analysis published just a couple of years ago. They compared IMT to no exercise, and they had better strength, better exercise tolerance, and better quality of life. Interestingly, in these patients with heart failure, there's better results for those who trained at least 40% of max. There's that echo of the signal we're hearing from other patient groups. And dyspnea didn't necessarily improve unless they got up to 60% of max. Okay, so again, nudging us as physiotherapists to think prescribing at the higher end of the spectrum, particularly for our patients with heart failure. This next slide gets some raised eyebrows from some of my colleagues, and I presented it around the world. What we do know is that IMT is still powerful and effective even in severely deconditioned patients, and it comes through in their quality of life scores. So I think we can afford to offer our patients with severe heart failure this at least one opportunity to make some significant improvements in their exercise tolerance. And I've come to think of inspiratory muscle training as a gateway exercise. What the clinicians around the world are telling me is if they've got patients who really are so disabled by their disease that they really can't even wrap their brain around starting an exercise program, if we start them on some inspiratory muscle training, they can literally do it sitting on the couch watching the television. It's not a very big ask of them to incorporate into their lives. And then once they feel less breathless, they can do a little more. They're redistributing their perfusion peripherally. You like to think about that metabo reflex. Then they feel capable and willing to try some other exercise. So I think that's pretty powerful for us to be aware of. Okay, So the next group of patients I would like to spend a little bit of time on is patients with Parkinson's disease. This may seem a little odd. Why on earth would we pick patients with Parkinson's disease? You wouldn't think that they are a group that particularly report dyspnea as a key feature, and they don't. But what we've discovered, we have the benefit of a Parkinson's exercise class that runs at the University of Canberra. Fabulous team of health professionals running that over there, and they get 100 patients through every week exercising in a group setting, which is just marvellous. But we asked the question, what is limiting our patients? And for a percentage of our patients, it is in fact their feeling of dyspnea that is their exercise limiting factor. So we thought, well, is that trainable? Can we take the edge off? And what else has been done in this space before? Interestingly, not very much. We found this one study back in 2005 that had looked at doing some inspiratory muscle training in people with Parkinson's disease, and they could actually find some benefits in terms of reduction of dyspnea with different loads with some training, so that it was the potential was there. But nobody's really picked it up and run with it really since then. There's a more recent review that looked at, well, what is the evidence? And again, the studies that were around, there's very few of them and they're not particularly high quality. So there's not enough even really to guide clinicians. And so of course we said, hello, that's a job for us. So we've been very opportunistic. Please don't tweet or share this next slide because we're submitting it for publication literally at the moment. But here's what we found. We've, in our particular cohort, bearing in mind these are patients with Parkinson's disease that are well enough to come in from the community to an exercise clinic, 36% of those that we screened reported dyspnea. So we offered them 6 weeks of inspiratory muscle training. So this was, we taught them in the clinic. It doesn't take very long, it takes less than half an hour. It's not very complicated. We showed them how to adjust the resistance and increase that over time. And essentially they would do the inspiratory muscle training at home while they were still coming in for the exercise clinic during the week. So we encouraged the patients to do 5 sessions a week. And again, the total training was just 30 breaths a day. And we tried to increase that resistance over time to try to keep it at a higher intensity. And what we saw compared, we've got the baseline score. And at week 6, we only did 6 weeks of training in this group. We saw improvements in their strength. They went from 69 to 88, for example. But what was very exciting is that we also were seeing here a reduction in their dyspnea on exertion score. I'm not very surprised that we didn't see much at rest because it's not the rest problem for these patients. It's much more when they're exercising, and quality of life certainly moving in the right direction as well. So this was a very small study, just acknowledging my other co-authors there, and it will probably not surprise you that based on this evidence, we've already launched our randomised control trial to see if there's actually the benefits of training. We're pushing it out to 8 weeks rather than 6 weeks, but it is certainly something that seems to be very well tolerated by the patients. They actually get quite competitive between each other. They like to come and say, "Oh, how much are you training at?" So it's another sort of string to the bow of their exercise repertoire. And given that there's very, very little in terms of adverse effects, we think it's sort of worth exploring a little bit more. So the last patient group that I would like to discuss this afternoon is patients recovering from COVID-19. And I'm going to talk a little bit about what we know in the very acute ICU end. And we're going to go right through to long COVID. So full disclosure, I am working very closely with the clinicians at our COVID recovery clinic here in Canberra. And we are doing plenty of research, collecting all the data we can to really better understand the place of exercise in this group. So I'll tell you what I know. So there was one study that was published in 2021 that was, these authors were brave enough to try some inspiratory muscle training in their patients who had just weaned from mechanical ventilation. So these are patients still in the ICU. These are patients obviously who are sick enough to be in ICU with their COVID. And at a time when many clinicians around the world were thinking, oh, COVID, take a step back, let's go really, really conservative. I credit these authors with being brave enough to go, let's apply what we know from every other disease process and see what happens. They had 42 patients, so it's a very small study, and they did threshold loading, the same as what I've described, but they did it for 5 minutes at 50% of max twice a day, 5 days a week. Again, only for 2 weeks. So again, we're seeing significant changes within 2 weeks. They looked at important patient-centered outcomes, including dyspnea, quality of life, and 6-minute walk test. And I was very excited. I may have done a happy dance when I read this study back in 2021, seeing that, yes, again, in these patients who had spent some time on a ventilator, if we manage to train them early, we're getting improvements that are actually meaningful and important even in those first 2 weeks. So the message here for me is, I'm not sure that the COVID part of it's that important. It's just consistent with the other disease processes that we see that almost irrespective of diagnosis, if they've spent some time on a ventilator, their breathing muscles are likely to be weak. It's advantageous for us to jump in early. Now, there's plenty of patients where we can't do inspiratory muscle training while they're still on a ventilator because they are delirious or not awake enough. And in these patient groups, sometimes we can't start the training until that sort of post very acute end. But that means that our hospital physios are really well placed to jump in there in those sort of acute recovery weeks and get that started. So that's pretty exciting. So let's jump from that to the story of long COVID. And I'm sure everybody is familiar with the fact that long COVID is very much with us for the foreseeable future. And some of the key symptoms that people are reporting to us include fatigue, weakness, functional decline, and lo and behold, breathlessness. This is a results of a living systematic review that was published not long ago, and they again tried to map really commonly described symptoms, and this is across patients both who were in ICU or hospitalised with their COVID, as well as those who weren't. Those were just managed in the community. And again, you can see weakness, malaise, fatigue, concentration impairment, and about 25% of people are experiencing breathlessness as part of their long COVID package. And again, we're seeing issues with reduced quality of life, not surprisingly there. So, has anyone been brave enough to look at inspiratory muscle training in this long COVID group? I'm going to tell you it is controversial to do exercise in this group for lots of reasons. I could give you a whole talk just on that, but I was very excited to discover this group of physios in the UK that had patients on a waiting list for their COVID clinic, and they were very opportunistic, and they grabbed some of the people off the waiting list and they were brave enough to start doing some IMT. And they did 3 sessions a week, 6 by 6 breaths at 80% of max. So that's on the higher end of anything I've shared with you this afternoon. That training took about 20 minutes per session, but only 3 times a week. So hopefully not too arduous. Again, this is home-based training. This does not require a lot of intervention from the therapist. So it's reasonably feasible and efficient. And the outcomes that they showed improvements included dyspnea, quality of life, and 6-minute walk test. So again, we are seeing that these, even just an 8-week training program, even in a long COVID context, can make a significant difference to our patients. And I get less and less excited about the strength changes. You know, sure, we can measure their maximum inspiratory pressure again, but I'm much more excited about their improvements in exercise tolerance and their improvements in quality of life, because that's what's going to make the difference to our patients. So it'll be absolutely no surprise to you to discover that at the COVID recovery clinic that is at UC Hospital, we have been measuring inspiratory muscle strength, and we have been prescribing inspiratory muscle training since we opened. And what we're seeing clinically is that you know, most people do have that reduction in their inspiratory muscle strength, and we can see that they can start doing that training, inspiratory muscle training, when they're not yet up to coming in and doing whole body exercise in a group setting. It's a really nice little gateway exercise again to get people doing something. And there's something about the training where they're seeing the actual settings on the device. Okay, last week I could only do level 2, now I'm doing level 3. It gives them a sense of progress. You know, they knew they couldn't breathe 6 breaths on that setting last week, and now they can. And I dare say there's some psychological benefits to seeing those improvements as well. So of course, looking forward to sharing some more data with you as we collect that. So we've been on a whirlwind tour. So in my summary about how we can reduce, who can reduce dyspnea with inspiratory muscle training, ICU survivors, you betcha. Okay, so we know that improves strength, quality of life, and dyspnea. If you happen to be working with athletes, yes, but they may be already onto that, especially if they're the endurance athletes, and that can absolutely enhance their performance. Those with chronic lung disease and heart disease, of course, we see those benefits also translating into better exercise tolerance for this group, which is so crucial. Parkinson's, maybe, get back to me in a year or 2, we'll have the results of our randomised trial and I can let you know. And definitely for COVID recovery, the 2 RCTs that we've got so far are very favourable. And remembering that dyspnea is a really key feature of long COVID for many of our patients, I dare say we'll see more and more in that space. And again, in the category of, you know, all the potential benefits and very little risk in terms of adverse outcomes. So I'm sure you're wondering, how do patients access inspiratory muscle training in this town? You have the benefit as a medical professional in Canberra of having one of the most skilled physiotherapy workforces in the country. about inspiratory muscle training. We're a little bit obsessed with it, just a tiny bit. And so your ICU physios right through to your acute physios on the ward, your community centres, obviously the physios at the COVID recovery clinic, and I even know a couple of physios that are doing some domiciliary type work that are offering it as well. We've kind of trained them up too. So if you want to prescribe IMT for your patients, please just start the conversation with your friendly physio. I'm sure they'll be more than happy to help. And I'm also very happy to field questions. You can find me at the email address there. You can also find me on Twitter. Thank you very much.
Fantastic. Thank you so much for that wonderful whirlwind tour, Bernie. That was really enlightening. So we already have questions. I'm going to bring the microphone, so hopefully everyone online can hear too.
Very interesting stuff. I've got two questions. The first is, how do you do double-blind or sham control studies that might be quite difficult? And the second thing is, how much does the equipment cost? I'm going to improve my
Yeah, absolutely. Okay, so the first question is great. So in terms of doing double blind, you in any physiotherapy intervention study, we can't blind, obviously, the therapist delivering the intervention. So that's one issue. That's just consistent. In terms of blinding the patients, again, very difficult because they feel the difference. I know there are some studies that take the spring out of the tube to take away that resistance. But again, it's probably very limited. And one of the issues is certainly in patients who are extremely weak. I know of a few trials now where they've tried to have a sham device, but unfortunately just the sham device itself appeared to actually offer a little bit of resistance that kind of compromised the difference between the groups. So it's actually really difficult. We have so far in our work compared it to just usual care. We're not particularly working in ICU patients because their baseline is just so very low, and that seems to be a reasonable compromise. We're at the moment designing a multi-centre RCT that's being led from Canberra and with collaborators in Brisbane, which is very exciting, but we had a long wrestle through, do we do a sham device, do we not, what are the pros and cons, and we've decided to just compare to usual care. And the second question was, how much do they cost? So the very cheap and cheerful devices that I use for most of my work, they cost about $30. However, the manufacturer has just stopped making them. Damn, I don't know why. So our next best option is a slightly more sophisticated device, but we have to import it from the UK. It costs about $100. So that is the spring-loaded device that the patient can keep forevermore. The devices that we're using in intensive care and on the acute wards, we have access now to electronic inspiratory muscle trainers. The advantage being that their training threshold, instead of being limited from, say, 9 to sort of 70 centimetres of water, we can go right down to 2 or 3 centimetres, right up to 200. So they cost a lot more. So obviously we don't send them home with our patients necessarily, but it does allow us to train even the weakest of patients in the ballpark of sort of $4,000 to $5,000 per device for that. So yeah, hope that answers the question.
Can you please comment on your AE selection? 1 and 2, comorbidities. How many do you take on? So someone has got diabetes, Parkinson's, and other issues. Do you take them on?
So I missed the first part of that question. Sorry, in which context?
Age selection. Age.
Oh, the age limit that we would take for inspiratory muscle training? Oh, I've done it in 90-year-olds. Like, I don't think there's an age limit to it. It's much more about whether they're able to be awake and able to do the training. The only contraindication, really, I won't do it in someone with a pneumothorax. That kind of positive pressure. If they had extensive bulle in their lungs, it might be a bad idea, I guess. But there's very few contraindications, I would say. But funny story, I'm not a pediatric physio at all. I've always worked in adults, and so I'll be the first to say I'm not an expert on little people. But I've been contacted by clinicians around the world working in pediatric ICU saying, well, when can we start using this? And I was like, oh, I think it's really important that they're old enough to understand, you know, what's happening so they're not distressed by it. I do know of one colleague who is using it in the NICU, and that just terrifies me. I just think, oh, those poor little babies, they're stressed enough as it is. But I had some gorgeous physios from Singapore that were in touch, and they were really excited. Yes, they're going to try it out in their this 12-year-old girl. They had fantastic, great. And we had a meeting a couple of months later online, and they said, oh, Bernie, we discovered it really doesn't go well in 2-year-olds. I said, no kidding. The poor little 2-year-old was basically having a tantrum by the end of the session. I said, please don't do it to 2-year-olds. I think that's a terrible plan. I really think they need to be on board and understanding that. So I guess that would just be my caveat about in terms of both age and comorbidities. No specific comorbidity apart from where pressure issues are a bad idea in their lungs, I guess. Yeah.
And you mentioned there was not very many adverse events. It looks really good. What are the sorts of things that could go wrong that you would?
Yeah.
You have, you know, side effects?
Yeah. So in the early days of looking at this, particularly in an intensive care setting, and you know, you're going to do what? You're going to take our patients off the ventilator to do this. We had to look really carefully at the safety issues. So we mapped very scrupulously oxygen saturation, blood pressure, heart rate, as well as their feeling about it. And our data from many, many hundreds of patients is nothing happens. It's incredibly boring. There's almost no blip on any of their measurements, which is great. If you think about it, they're only coming off the ventilator for like 6 breaths. It's not a big ask. And so we've been really hard pressed to find any adverse effects. The only adverse events I can share with you are, if you go hard enough with your training, it is possible to create delayed onset muscle soreness in your intercostals. Ask my physiotherapy students that try it on the highest setting and just to see what happens, just to give it a go. Yeah, they've managed to give themselves some impressive DOMs, but yeah, that's kind of the worst that happens. There's certainly been no concerns about any serious adverse effects from any of the studies that I'm aware of. Yeah.
Can I just ask about, sorry. Well, what about other lung diseases like pulmonary fibrosis? You've done COPD, but there's not a restrictive problem.
Yeah, great question. And I get this a lot. Like, what about this other subgroup? And I think there's reasons perhaps to be cautious, but not reasons not to try would be my answer. And I think the more I present about this around the world, the more people are like, but we should try this group. Spinal cord injury is another one. The incomplete spinal cord injuries, couldn't we? You know, there's so many different subgroups. So I think it would be worth exploring, absolutely. Particularly, again, if you take the mindset that it's obviously not going to change the underlying pathology, but insofar as there's going to be a disuse element that's contributing to their dyspnea, why wouldn't we give it a go? Yeah, there's a whole bunch of patients I haven't even discussed this afternoon, and that's around pre-op, post-op patients and the risk of pulmonary complications. There's some very nice data that even 5 days of pre-operative inspiratory muscle training reduces length of stay on the other side. So if the surgeons get onto that, I think physios could get really busy. And the reduction in PPCs has also been seen in patients with stroke, would you believe? So people have actually started exploring that. But I suspect that we've just scratched the surface of the potential applications of this. And again, you know, cost is very small. Even from a physiotherapy time cost, it's not very big. Patients are empowered to do it themselves. I think there's a lot more patients potentially that could benefit.
Sounds like we've gotten very positive results across the board, particularly as a lead intervention to whole body exercise. Adverse effects aside, have you had a cross-section of patients that go through the full therapeutic course and just don't see any benefit?
I would struggle to give you an example of that, but of course I'm biased. I'm a physio. We get very excited about our patients improving every day. And of course it's hard to tease out what is the IMT versus what is the rest of their recovery, you know, but it would be, yeah, really difficult to see someone who's actually gone through and done all the reps and every single patient tells me, yeah, they can feel the difference. Even if it's not, I'm thinking about some of the long COVID patients, even if it's not fixed, it's markedly better than it was, you know, and I think, you know, if it's just basic strength training principles. Now, again, we could have arguments, is that actual muscle level change? Is it the perception of dyspnea? Are we just getting to tolerate different levels of discomfort and take the edge off that? Entirely possible. I think I could absolutely team up with a psychologist and go in a completely different direction with understanding the mechanisms. But I'm less excited about the how. I'm much more interested in what's making a difference to the patients. Great question. Yeah.
Thank you very much.
There's a question in the chat.
Oh, question in the chat. Oh, any studies on sleep apnea? Oh my goodness, such a topical question, because I got asked about that. I did a Zoom call with someone in New Zealand just 2 weeks ago, because there isn't a lot of evidence about the place of IMT in obstructive sleep apnea. And so we've started talking about getting some pilot data and exploring that as a new area. So I'm sorry, I can't tell you much about that. It's, again, uncharted territory essentially, but hopefully we've got some physios that are already starting to have a look at that.
All right, well, I think we better bring it to a close there. I think if you'll all join me in thanking Dr. Bissett very much for this wonderful report. I feel like, you know, maybe one day fairly soon we're going to be seeing these little devices at the bedside rather than the bubble machines and things, you know, in the hospital. So look forward to the next update on the research.
Thank you.